Hello, hello, hello. Hello, my friends. Hello there. It's Jill Osborne from the Interstitial Cystitis Network. It is Sunday, March 6th, 2022. Time for another IC support group meeting. And let's see here. Hold on a sec. Let's get Facebook up and running. There we go. Oh, hello, my friends. Jill Osborne from the Interstitial Cystitis Network. It is Sunday, March 6th. It is time for another IC support group meeting. My purpose in doing these meetings is to make you so strong, so knowledgeable, so informed that no one can mess with you again. I don't want anybody to minimize you, demean you, tell you that this is all in your head and all that sort of stuff. This is real, this is treatable, but it's complex. There are a lot of elements to IC. So let's give it a minute or so. Let some people come on in. I didn't have time. I did not have time to clean up my office this morning. Sorry about that. It is what it is. In fact, look at this. Let's just move this into the middle and we'll just cover up my. Hello, Facebook. Hello, YouTube. We're streaming live right now on Facebook. If I'm looking here, I'm looking at Facebook. If I'm looking over here, I'm looking at YouTube. And normally when I do these meetings, we do a little 30-minute riff on something related to IC or Hunner's lesions or bladder pain or whatever. And then I usually take your questions. Today, though, I'm probably going to cut out a little bit early because there's something else that I kind of need to do. Last weekend, we were just launching our new COVID cystitis website, covidcystitis.org, which is very exciting. Now we have some resources for patients who have COVID cystitis, the only website dedicated to COVID cystitis. Hi, YouTube. Hello, you guys. We have got our magazine done. So the IC Optimist is now at the printer. It is now live on our website. It is not on our member pages yet. I need to do that. I was working on that last night. So for those of you who are ICM members, you'll be able to get it probably tomorrow. I think I'll probably have it up tomorrow. We don't have a lot of news in the IC world. Hello, Caroline from England. So nice to see you. I hope you guys, is the sound okay on Facebook? You guys good with that? Hi, Sherry. Nice to see you, hon. I think today's just, I think today's kind of one of those days where we all just kind of need to take a step back, take a couple of deep breaths, go sit in the sun if you can, and just have a nice break. Right? Right. I know I definitely need my own breaks too. Hello, Heggy. Nice to see you, hon. Hello, Caroline. Good. You can, yes, the sound is working. Excellent. The sound is working. So what's on my table? So we're still waiting to film a new TV show, hoping to film yet more new videos on IC and pain. I hope that you will help us spread the word about the new COVID cystitis website, covidcystitis.org. Please share that if you can. Nancy said, since I had my interstim implant, I no longer have IC issues. That's great, hon. That's good. I'm so glad that it's working for you. Interstim is a step 4 treatment option. We have 6 steps of therapy as published by the American Urology Association. And the steps are arranged with respect to the risk of adverse event. So we want you to do the easy stuff before you do the hard stuff. So interstim is in step 4. There are 2 forms of neuromodulation. One is ankle stem, also known as urgent PC. The second is sacral or pudendal neuromodulation, known as interstim. Interstim is it's a rough therapy in the sense that, Nancy, it does have to be monitored, right? You do have to monitor your interstim fairly regularly. Let's make sure that the battery's working correctly. If you're getting shocked, if you're having any other issues, The challenge with interstim is that it does have to be very, very consistently monitored. So how often are you going to the doctor and having it checked? I'm really, really glad that it's working for you. Most people will first try the ankle stim first because the ankle stim, known as post-tibial nerve stimulation or urgent PC, does not require surgery. Kayleen says, the UA I talked to you about on Friday did have the culture come up as negative, but you're in so, oh, Kayleen, honey. Well, you've got, don't you have an appointment on Monday? Hi, Miranda. Hi, Kieran. Nice to see you, hon. Hello, YouTube too. Nancy says, every 4 months. So far, it's been going well. Most of the time, I forget it's there. Good. Nancy, did they tell you with your interstim? Because I know that they're always working on new technology. One of the barriers of interstim therapy originally was that you could not have MRI. You could not have certain diagnostic imaging because you had metal in your back, that metal could potentially heat up and damage tissue. But I think I just read, like in the last couple of months, that they have the new implant is more friendly to various screening techniques. Hello, Cassandra from California. I'm in California too. It's a beautiful day here. Beautiful sunny day, very cold. So Nancy says she does have the MEI compatible interstim. That's great. You know, Ken Peters just put out on his Twitter feed. So Ken Peters is probably the most preeminent interstim surgeon in the world. He's at Beaumont Health in Michigan. And he was one of the first doctors to really start working on it after it transitioned over to Medtronic. And he's known for being a very, very meticulous doctor. Anyway, what did he say on his, hold on, let me look at his Twitter account. It's always cool to see what the doctors are talking about, right? Let me go to his account. I know it was a picture of him, and I know it was a picture of him with the device. God, there's so many Ken Peters on. Hold on. Where are you, Dr. Peters? Where are you? Huh. Weird. Oh, here he is. He's under Kenneth Peters, not Ken. Kenneth Peters. So let's see here. He said he did his first interstim in 1998 when it was a big cut down the center of the sacral fascia, where they identified the foramen, placed the lead, and sutured it into the periosteum. Glad the technology has improved. Neuromodulation has been life-changing for my patients. Let's see. Did my first interstim X 10 to 15 years. And he has a little tiny picture. It looks like the new interstim device is like this big, where the old interstim device was like this big and this thick and really stuck out of your tush when they implanted it into your back. So that's very cool. One thing you might not know about urologists, such as Dr. Peters, is that they are very, very dedicated to working internationally. And so Dr. Peters once a year will go to Africa for several weeks to do work down there and train surgeons down there. So did Chris Payne. Chris Payne was notorious for going to Africa to work on repairs. He's a board member, if not maybe the president of an international nonprofit working with that. Chip says, does anybody know if Medicare covers interstim? I think it does. Medicare covers both interstim and pudendal nerve, the post-tibial nerve stimulation. Antonio. Hello, Antonio. Nice to see you. I've been having IC symptoms for 2 years. I'm a 48-year-old patient. Dr. Chris Payne and Jeanette Potts did a cysto last July. They suspected that you have a high bladder neck, which I think can happen in both men and women. Do you think high bladder necks can cause IC symptoms? Well, hon, you were with literally one of the best in the world, Dr. Peters and Dr. Potts. Those two together are definitely a dynamic duo when it comes to pelvic pain, especially pelvic pain related to the bladder. Possibly. I will just say, and I know that this is controversial, and I know that people disagree with me. At least one specific person tends to disagree with me when I say this, but in my clinic, in my office here, including this week, every single guy who called me, we could find a pelvic injury in their history. And so that would be one thing that I would really want to know about your symptoms is, did you associate the onset of your IC symptoms with any sort of activity? Were you a bike rider? Were you a football player? Were you in the military? Were you did you fall? Was there any sort of trauma? And then the other thing, Antonio, I know that they did that. I know that they did this. When they did your pelvic floor assessment, what did it find? Did you have tight pelvic floor muscles? Cecile says, hi from snowy California. We'll check more information through website since I am deaf. Stay warm and take care. Hi, Cecile. I wish you well, honey. I wish you well. Nancy says it's called the microshape of a thumb drive, but smaller. Medicare and supplemental insurance covered. I had to pay $325 for both the wire surgery and interstim. The surgery was $79,000 altogether. Yikes. So Antonio, yes, you were a bike rider. Hi, John. Nice to see you. So Antonio, so here's the deal. Riding bicycles put absolutely the worst kind of pressure on your bits down there. When you sit on a bicycle, it's literally pushing directly up into your pelvic cavity. It's directly pushing up against your pelvic floor and or the various nerves, such as the pudendal nerve. And that will often create a foundation for other issues over time. You may not know that your muscles at first are part of the problem. You may have latent trigger points, but slowly over time, that injury worsens. Those muscles get tight. They start restricting blood flow to the bladder. You end up with ischemia. But in the end, it's still about those tight muscles. So did they do a pelvic floor assessment? One thing about Dr. Payne's clinic is they had literally one of the best physical therapists on the West Coast in his clinic that he referred patients to. Carol says, I've been suffering this week. I have constant frequency and burning pressure pain. Been taking azo, baking soda in water, D-mannose, marshmallow root tea, Peora, bladder rest, Vicodin, Alep. Girl, honey, that's one hell of a flare. You went to urgent care. Your appointment came back negative. You have an appointment with my urogynecologist on the 5th in a month. I haven't seen him in over a year. You're overdue for an exam. He usually pushes the OAB meds, lidocaine instills. Is there anything new that I could bring up? Yeah, you could bring up platelet-rich plasma. That's certainly something new that more doctors are doing. It's always important to try to understand the underlying anatomy. I mean, why do you think you're flaring this week? What happened a week ago? Any idea? I mean, is this a bladder wall flare? Is this a pelvic floor flare? All right. Antonio says this makes sense. Sitting on a hard surface too causes you lots of issues. Exactly. Antonio, hold on a sec. Let me grab this book. You know, the thing that we all have to remember about the pelvis, and this is something that Dr. Weiss reinforces in this book. Dr. Weiss wrote this book, Breaking Through Chronic Pelvic Pain. Fabulous resource, especially for anybody with a history of pelvic injuries. And in its introduction, he says, listen, Western medicine fails the pelvic pain in the IC patient. Why? Because doctors play in their sandbox. Urologists tend to stay in the urinary tract, gynecologists stay in the reproductive tract, et cetera, et cetera. Hold on a sec. I got something bugging me here. Gastroenterologists stay in the bowel. And here's the deal about the pelvis. It's a very small confined area with a lot of stuff going on, and nothing operates in isolation. I mean, think about your pelvic cavity. You've got your organs, you've got your skeletal muscle, which helps you move and walk and open your legs and close your legs. You've got your blood vessels, you got your nerves, et cetera. You got your bowel, et cetera, et cetera. And they're all right next to each other. They're influencing each other. Some people, for example, and I'm one of them, which is so weird. This is one of the weird things, is that when I was in my 20s and a lot of this was hitting me and I started getting, I had the IBS for the first time, and because I'm IC subtype 5 central sensitization, I distinctly remember I used to love to lay on my couch on a weekend afternoon and read. I still love to do that. And as I was reading, the bottom of my feet started tingling, just like a little fluttering, but it was more like a tingle, like a soft tingle. And, you're just kind of going, okay, that's so weird. What is that? Couldn't really figure it out until like 10 minutes later, I had to have a bowel movement. And then I started making that connection that I would have moments when my feet would start tingling. And it's like, okay, gotta get close to a bathroom, gonna have to have a bowel movement soon. And that's because the nerves are literally right next to bowel too. And so sometimes if you have something hard going through your bowel, as it passes that spot where that nerve is, it pushes against that nerve and causes that tingling. It's very, very interesting. It doesn't happen as much now. I think I've got my muscles in good shape and I've got things calmed down there, but it used to happen all the time. So anyway, nothing operates in isolation. Everything influences each other. Tight muscles influence organs, dysfunctional organs influence muscles, et cetera, et cetera, et cetera. All right, hold on. Let me see if I can find this picture. I just should have Post-its on this book. Where is it? Here it is. Cyclist syndrome. So this is a perfect example, perfect drawing of where a hard bike seat hits. It goes right up into the pelvic cavity, and where it happens to end up hitting the clitoral penile branch of the penile canal under the pubic arch, and the perineal rectal branch in the Alcock's canal within the sit bones, right? So you can directly see that bike seat hitting these nerves right here. That's why we call this cyclist syndrome. Very, very common. Here we go. Direct trauma that compresses the nerve. Bicycle riding. Direct trauma of the pelvic floor and perineum most often occurs from riding a bicycle with a seat that exerts pressure on the pudendal nerve inside the sit bones and under the pubic arch. Pressure that is intensified by pumping the pedals. Appropriately dubbed cyclist syndrome, this variation of nerve compression sidelines a lot of serious bikers and more than a few weekend enthusiasts. While sitting, the fat located between the sit bone and the rectum pushes up against, anyway, this is more, let's see, the bicycle seat also exerts pressure on the nerve within the clitoral penile canal under the pubic arch. Yeah. Okay, and direct trauma to the nerve can similarly occur from sitting on hard yet uneven surfaces. So, did you tell Dr. Payne that you were a bike rider? And again, did you have that pelvic floor assessment? If they did, what they find? Now, listen, I'm 5 minutes behind on Facebook right now, so you might have already answered that question. So you can give me a moment. Shanna says, I'm having slight pressure and increased frequency overnight when I have Tyler's acid-free coffee at around 8 a.m. No issues until 16 hours later when I'm attempting to sleep. Is this just reacting to the caffeine since you're not used to it, or would you consider that a flare? Nighttime frequency is often a direct result of something during the day that's irritated you. The reason why we flare at night is because we have fewer distractions during the day. There are so many other things happening that it's fairly easy to ignore, a slightly wonky bladder. But by the time everything's quiet and calmed down and you're getting ready into bed and you just don't have that distraction, that's when you feel it. I would lose the coffee. Honey, I would lose your coffee for 2 weeks and let's see what happens. And when you're ready to go back to coffee, I would maybe try, why don't you try the Dandy Blend herbal coffee first? I don't think that would trigger it at all. In fact, here's my cup. I just made this. I just made this latte about 5 minutes before I started this meeting. This was supposed to get me through this meeting. Oh, that's good. Chip says, I started an 8-week regimen for bladder installations. My urologist also wants me to see a pain specialist to do a pudendal nerve block. Do you know how that is done? My urologist didn't know. Uh, uh, this is Karen, right? This isn't Chip. This is Karen. Karen, they do it through your the top of your vagina. I've had a couple of them myself. It's not terrible, but it's odd. I wouldn't worry about having it done. It'll be very, very interesting to see if having that pudendal nerve block turns off your pain. Hi, Mary. I got to tell you, I had a really interesting conversation with a patient on Friday, and sometimes getting information out of you is hard, because number one, it's embarrassing and you don't want to talk about it, or you might not understand that something is important. So I was working with a sweet woman who really struggling with symptoms, kept saying, focus entirely on bladder. Should I do bladder stuff? Should I do bladder stuff? Et cetera, et cetera. And we were kind of going over those options with her. And then it's like, okay, you are an anatomical mystery to be solved. Something just kind of tweaked me here. And I said, so how's your pelvic floor? And she's like, oh, I don't know. It's like, okay, well, so is sex painful? Yeah. Do you dread going to the gynecologist to have an exam? Yeah. When you go to urinate, do you hesitate? Yeah. Can't start a stream right away sometimes. And then we said, okay, do you have any history of trauma? She'd had 4 C-sections and then another additional laparotomy for endometriosis. And then there was something else going on. And so it was really clear this patient, who had just started having bladder symptoms recently, had a long history of pelvic issues, right? So I just started talking to her about the muscles and trying to educate her about how long-term muscle dysfunction can trigger the bladder, et cetera, et cetera. We talk about this all the time. But then, again, I kind of got a little tweak there, and I said, now listen, I don't want to embarrass you in any way, shape, or form, but I just want to ask you a question. You don't have to answer this if you don't want to. Do you ever have moments where you feel this painful arousal sensation? And she got very, very quiet. And she's like, yeah, she hadn't told anybody about it. And I said, interesting. Okay. So I explained, I jumped right in and said, okay, that's called persistent genital arousal disorder. That means you have a muscle so tight it's squeezing a nerve. I said, well, how long has that been going on? For years. She has had issues for years. And so then we were like, kind of expanding this discussion a little bit more. And I'm like, okay, so we know definitely you have tight muscles. We know definitely that you have a nerve involvement in some way. So have you ever had a tailbone injury? And she went, oh my God, like, how did you know? And she said she had gone to physical therapy, like, I don't know, years ago. And they used to have to physically push her tailbone back into the correct position. And so she was the perfect example of someone, and I was just very honest with her because all of her symptoms actually literally began in childhood. And I sent her back to her mom and said, let's see if we can find any sort of physical trauma. What happened to her tailbone back then, right? Fascinating case. But, it's like getting water out of a desert sometimes. And as much as easy it is to be focusing on bladder, you have to understand that sometimes other things in the pelvis will trigger those bladder symptoms that you don't. And in her case, she had perfectly normal bladder, just like me, perfectly normal bladder. Diagnosed with IC, but her bladder is perfectly normal. But now we understand why. It goes back decades, clearly to something that happened in her childhood. Carol says, I drank some ginger ale and ate pizza. I know I'm not supposed to drink ginger ale. And the tomato sauce in the pizza, I do have pre-leaf. Yep. Well, okay. Hege says, the tense situation here in Europe has made me flare big time. Honey, I'm so sorry. Can you imagine how challenging it could be for anybody who's being treated for cancer, who is now is either stuck in Ukraine or has had to flee Ukraine or IC. It's heartbreaking what's happening. I talked to one of my counterparts in Europe early last week, and she was in the on the western coast of Europe, and she said that everybody's stockpiling, that the supermarkets have bare shelves again because people are very, very concerned that the war is going to reach into Europe. They're also very deeply concerned about nuclear war. Carol says, can you repeat what you said, the new thing I should write down to my doctor so I can write it down? Thank you, Marcia. Antonio, could shockwave therapy restore blood flow and nerve function? Maybe, but what's far more important is trying to fix the muscle in the long run. I mean, physical therapy, dude, it's physical therapy all the way around. You have to work on those muscles. Muscle therapy it cures patients. That's why when Dr. Payne released his 5-point subtyping system, he said it's a crime to tell patients that they have an incurable bladder disease. For many of you, you have a healthy bladder. It's your muscles. It's something else that's going on. Also, Antonio, given the fact that, you have symptoms of pudendal neuralgia, you have to make sure, because you have pain when you sit that is relieved by standing. Come on over to our website and read our section on pudendal neuralgia, that subtype information. You might really benefit from a chair cushion that has a groove down the middle whenever you need to go sit somewhere. Let me go get it. My dad is sitting on my sample. Hold on. Let me go get it so you can see it. All right. Checked in with the folks. They are good. Dad had his milk toast. He loves his milk toast. My mother had fiber English muffins with cream cheese. There you go. Okay. So when we're thinking about sitting, if you have sensitivity around your urethra, your testicles, your vagina, your vulva, and especially your rectum, you don't want to do a round cushion. You don't want to do a donut. Donut cushions put weird, unusual forces on your pelvic floor. You're going to do better with a cushion like this, where each butt cheek is supported, but there's nothing pushing up directly up into your crotch area. Now, we had past tense, we sold for like over 20 years, these great chair cushions. Actually, this is one of them without the cover on. They're super inexpensive, worked really well. Unfortunately, the factory closed because of COVID 2 years ago. So we cannot get these cushions anymore. You could potentially go to a foam store in your area. You can see the design, right? It's 16 inches wide by 16 inches deep, wide 16 inches wide. Each cushion is like 7 or 8 inches with 2 or 3 inches in the middle here, right? You can glue them together, but we just can't get our old Caustics cushions. So the next best cushion that we were able to find this is one variation of it. This is called a CAPS cushion. And the company that makes this, obviously, it's actually a better cushion than the cushion we used to sell. It has better fabric. It has better foam. And because it's better, it's more expensive. So our old cushions were in the low 30s. These cushions are in the high 60s, low 70s. But they will last much, much longer. So the cool thing about this cushion is you can switch it around. I mean, if you have pain towards the front, then you're going to have the opening towards the front. If you've got pain towards the back, you're going to have opening toward the back. They also have a really good travel cushion, which is more like this one. And it has 2 handles on it, and it will fold up like this, and you can carry it. So you can find those cushions in our store if sitting is an issue. That's a key thing about pudendal neuralgia. I keep having a piece of hair over my face. What is this? Something's making me, what is that? There it is. Okay. The key thing about pudendal neuralgia is that you're not supposed to force through the pain. If a position hurts, get out of it, because the fact that the position is hurting is telling us that something is pressing on a nerve at that very moment. Okay, so we got to back off, give the nerve an opportunity to heal, give the muscles an opportunity to calm down. Carol says, also experiencing a lot of stress. Yeah, we all are. It's a difficult time. Antonio said, yes, you told them, and Dr. Potts did a pelvic floor assessment. There was definitely pelvic floor issues per their assessment. Both amazing doctors. Yeah, they just retired. You've been doing physical therapy. Excellent. And that's helped a lot. Wonderful. That's really going to be your best line of therapy right now, along with maybe some PEA, it's called palmitoethanolamide, which is a very simple supplement that calms nerves down. It's called Peora. Where is my Peora? Where's my sample? Where is it? Well, hold on. All right, I'll just show you my bottle of Peora. This is the bottle that I'm currently working on right now. Peora. So palmitoethanolamide, palmitoyl-ethanolamide, in an IC research study presented in 2019, 87% of patients reported a significant reduction in their pain and discomfort by month 3, and by month 6, a significant number were now pain-free. This is actually what has worked for me the most, because I have a healthy bladder. I don't need to focus on bladder therapies at all. I focus on muscle and nerve therapies, and I'm much, much better for it. Let's see here. Hold on, I'm just trying to get my computer good here. Let's see. Shana says, I did the coffee challenge like you recommended, chamomile tea, then dandy blend, then pumpkin spice rooibos, then Tyler's. No issues up until the Tyler's. Yeah, well, the caffeine is going to be a problem. She's wondering if it's just the caffeine. I mean, you could always try decaf, but, you know, caffeine is neurostimulatory, hon. You're going to pee more if you do caffeine. No doubt about that. Abby on YouTube said, I'm suffering with IC for the last 8 months. I've tried step 1 and 2 treatments. My main issue is a swollen bladder and burning urethra. I don't know where to go from here. Abby, I have a great blog on our website called The 7 Causes of Urethral Pain. The very first thing we look for in somebody with urethral pain is going to be estrogen atrophy. So how old are you, hon? How old are you? Rindy says, feeling badly this week. Urine specimen showed blood. Rare. White blood cells, rare. Doctor said no infection. A lot of stress contributed for sure. You have oxalate crystals moving, which is so painful on top of the flare. The burning is awful and the pain is bad. Can't get a good stream going either. Well, Rindy, the fact that you can't get a good stream going, I mean, why do you say you have oxalate crystals moving? I mean, and you guys bear with me. I don't reread the notes here. I don't read the comments here. So things you might have told me in past weeks, believe me, I'm probably not going to remember. Doctor said no infection, a lot of stress. Absolutely. I have oxalate crystals moving, which is so painful on top of the flare. Okay. Judy says, my doctor has me trying to retrain my bladder. I try and wait to pee until I can't stand the pain. The longest I can wait is 2 hours. Well, the bladder holding protocol is not meant to be done if you're in pain. The bladder float, that's actually when they say not to do it. Because if you're forcing your bladder into pain, you're activating the pain cycle. So, and that was from a conference we did in 1994, when we had one of the experts in bladder training come and speak. And he was like, listen, we really only want to do this for patients who don't have pain. So if you're holding it to the point that you're crying, you're kind of defeating your purpose because you're just working up your nervous system. Karen says, thanks, Jill. I'm wondering how much my tailbone getting broke in my younger age is affecting everything. I know, right? Karen says, how do they diagnose pudendal neuralgia? Well, they look at your symptoms. They again, a movement-driven symptoms, pain when you sit down that is relieved by standing up, positional symptoms. They're going to look for pins and needles, nerve-driven pain, which tends to be more electrical pain, persistent genital arousal disorder, sciatica. That's all evidence that nerves are being compromised, usually by tight muscles. All right, Abby back on YouTube says, sorry, forgot to mention 25-year-old male. Oh, cool. Nice to meet you. I don't think I'm pronouncing your name correctly, and I apologize for that. Oh, okay. All right. So, so it's not Abby, it's Abhay. You let me know if I'm pronouncing it correctly or not. All these issues happened after COVID in July of 2021. I've been doing PT for 3 months. So, honey, you have COVID-associated cystitis. Just built a brand new website on it, covidcystitis.org. This is common. The challenge with COVID is that it triggers this massive inflammatory response, and it's that inflammatory response called the cytokine storm, which damages the lungs and damages tissue throughout the body. Well, guess what? That's also happening in the bladder. They have found inflammatory mediators in urine. We definitely know inflammation is also affecting the bladder. And so a number of patients post-COVID have developed IC-like symptoms. And so number one, you have to do everything that you can to protect your bladder right now, because your bladder is in all likelihood quite inflamed. This means no caffeine. You're going to have to follow the diet and be as gentle as you can with those tissues. So no soda, no coffee, no green tea, no black tea. Anything that has the potential of triggering irritation, you're going to need to avoid. With respect to therapies, we have the whole treatment lineup over on the covidcystitis.org website. Yeah. And so I have all the research studies, all the publications. We literally just launched it a week ago. All the publications which have talked about COVID cystitis, as well as the few treatment suggestions they have. I'm working with a lot of doctors, asking them for treatment suggestions. It's still a wee bit early to know exactly what's the best. So some people, like the researchers in Michigan, are saying to do overactive bladder therapies, while others are saying to focus on things that will calm nerves down and be calming and soothing to the bladder. Yeah. It's a big deal, honey. It's a big deal. And I'm sorry that you're going through that. The good news is that it appears to be short term. 3 to 4 to 5 to 6 months. But again, if you're pouring acid on a wound every day, it's going to go longer and longer. So it's been 8 months for you. Have you been following at least any of the basic diet suggestions? That's what I would really want to know. Randy says they're not full-blown kidney stones, but oxalate crystals that form some of the kidney stones. Okay, you can feel them mixing through the urethra with the blood be from my IC bladder lining. Well, I mean, kidney stones are kind of known for triggering a little bit of blood flow from the kidneys. So you could have a little bit of blood coming from your kidney. Oxalate crystals in particular can be very sharp. And sometimes they're smooth. Sometimes stones are smooth. Sometimes stones are jagged and have rough edges. And as that rough edge is going down the ureters, it irritates and potentially traumatizes the skin in your ureters as well as in your bladder. All right, Abby says, yes, you're doing the IC diet, even the low oxalate diet. Your doctor wants to try bladder instills. I think that would be a reasonable thing to do, hun. Step 2 treatment option. But have you, you know, it would be very, very interesting to see if a rescue installation was helpful. So a rescue installation is a little bit of lidocaine with a little bit of heparin, with a little bit of sodium bicarb and maybe a steroid. That would be fascinating to see if that made your symptoms go, if that improved your symptoms, hun. It's called a rescue for a reason because it rescues you out of a flare. And that's what they want to try to do. They're trying to rescue, they're trying to coat the bladder, try to protect the bladder, but at the same time, they're turning the nerves off with the lidocaine or the marcaine. Diane says, will you experience back pain if you have interstitial cystitis? Yes, but the back pain, I believe, is usually coming from tight pelvic floor muscles. Let me get my model here. Here we go. So let us look at the pelvic cap. Whoops. My bowel tried to roll off the desk. All right. So here's your pelvic cavity, right? See, there's a lot of stuff happening in your pelvic cavity, a lot of stuff that fits in here. At the very bottom of your pelvic cavity, you have got your pelvic floor muscles, your skeletal muscles. But the thing you've got to understand is that you have muscles that go from your legs and end up attaching up into your pelvis. You also have muscles that come down from your torso and your back that come and attach down here. Specifically the psoas muscles. A psoas muscle is a big, like it's really big. It's like this big rope of muscle that starts in the pelvis and goes up both sides of the spine. And I will tell you, because I have scoliosis and my left psoas occasionally spasms, especially if I twist. Hold on, I need a drink. Getting over my sinus infection here. Remember last week I was super congested, sinus infection. So I'm on my 6th day of antibiotics, and I'm definitely feeling better, but I'm still a little congested. At least my teeth are not throbbing like they were. You know, let me just see too. Hold on a sec. God, I love this book. I love this book so much. This is the book to get, in my opinion. See, I jinxed myself. As soon as I said I was feeling better, I started getting congested. I just wanted to see if he had a good a good picture of the psoas muscles. Well, I know it's in here. I'm just not going to find it. Abby says, how do I feel about platelet-rich plasma therapy for ICM in the U.S. and I can't find any studies here? I'm all for it. In our magazine that's just coming out, we have 2 more research studies which show the platelet-rich plasma is absolutely successful in reducing symptoms, but more importantly, repairing tissue. And let me grab this. So this is the final draft of our magazine, our winter magazine. And let me just pull out these research studies, and I can talk them to you. Here we go. Platelet-rich plasma structurally improves the bladder wall. This study from China sought to determine if platelet-rich plasma improved the structural integrity of the bladder wall, specifically the urothelial cell growth, cytoskeleton, inflammation, and barrier function protein expressions in patients with IC. 19 patients with IC-BPS underwent 4 monthly intravesical PRP injections. Bladder biopsies were taken at the 1st and the 4th treatment. After injections, the functional bladder capacity and maximum flow rate increased. The visual analog scale of pain, symptoms, yada, 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 they all improved. But here's what's important here. The level of urothelial barrier function protein and cell proliferation protein expression in patients was increased after repeated intravesical injections. They may have potential to improve urothelial health and result in symptom improvement. Okay, hold on a sec. I could have worded that better. And here's our second study from Italy. Does platelet-rich plasma help bladder healing? Researchers in Italy reviewed the efficacy of intravesical platelet-rich plasma injections in IC. Treatment with a PRP appears to show less bleeding, fewer inflammatory cytokines, and an increase in the healthy division of urothelial cells in animal testing. In 3 clinical trials reviewed, patients who underwent monthly PRP injections were found to have a statistically significant improvement in symptoms with modulation of growth factors and inflammatory proteins. This suggests that this treatment could improve urothelial regeneration and reduce chronic inflammation. All right, so I know that there are some doctors in the U.S. who are already talking about platelet-rich plasma and doing it. John says, is it still considered experimental? Yes. It's going to be very interesting to see what the new AUA IC guidelines say. I hope that they will list it. Kathy says, can you look back? Kathy, sometimes it doesn't let me scroll back. I'll try. Oh, here we go. You're in the process of getting disability for your IC. I'm the one who was told my bladder needs to come out because my bladder is 50 cc's and only holds 2 tablespoons of urine. Holy moly. His office manager called and said she wanted to let me know that they would never say someone is disabled from IC. So now I'm having a problem getting disability after losing my job of 37 years that I loved. She said, you can pick up a pen and write. I said, I can't concentrate and I urinate constantly day and night and can't sleep, which is most of the time. How do I sign up for your newsletter? Kathy, just go on over to the IC Network website or actually go to the top of our Facebook page, right underneath the picture. And I think that there's a button there for you to sign up for the newsletter. You know, that is cruel. That is cruel that you have an office manager saying you can just write, you can take a pen to paper. They're not accounting for the fact that you're sleep deprived. And if you're sleep deprived, that means that cognitively, you're probably not going to be on your best. You're distracted. You're in pain when you sit. The longer you sit, the worse it gets. I am stunned. You know, listen, there are 2 forms of disability. There's state disability versus federal Social Security disability. State disability is designed for short-term disability. They only give it to you for a year, and it's designed to help you get back to work. So most IC patients start on state disability. I got state disability for a year when my IC was very, very severe, and I couldn't sleep at night. I was a wreck. Physically, mentally, and emotionally, I was a wreck. And that was from spring of 1993 to spring, summer of 1994. And I absolutely got state disability. That was my right. I paid into it out of my paycheck. I certainly had the right to get it. And state disability, again, because it's designed to get you back to work, the doctor doesn't have to say that you're totally disabled. So that might give you a bit of a transition. But the second step is when you go for federal disability, the objective or the intent of federal disability is that you're not going to be able to work again. Social Security has an IC ruling. You can visit that on our website, read that on our website. We have a Social Security Disability Center right on the IC Network website. My job in between, before I got my master's degree, I spent a year working for Social Security. I was a black lung specialist. That was my goal. I mean, that was how I was trained. I was a black lung specialist here in California, where we rarely had black lung. So I worked with all sorts of different types of people. And you know, I think so like you have to understand that interstitial cystitis is not an immediate Social Security approval. It's not. They have a ruling for it. They have a ruling, which means they're telling employees, disability evaluators, how to look at IC, but it's really the totality of your issues. It's, do you have any other issues going on? Are you a chronic overlapping pain patient where you have IBS and vulvodynia and all that sort of stuff? What is your frequency level? What is your pain level, et cetera, et cetera? If that was your urologist who said that to you, then I think that I would certainly get another opinion. I mean, if your bladder only holds 50 cc's, you are absolutely a candidate for bladder removal or bladder augmentation. You would be a perfect patient to participate in the bladder regeneration studies at Wake Forest. They're exactly what they were looking for. And any sort of bladder surgery has a long recovery time. And so we're looking again at that short-term disability as perhaps a transition. Kathy, if you'd like to talk this week, if you call me on Tuesday or later, I'd be happy to talk with you, hon. We have a whole Social Security Center on the IC Network website. Please go look at that. It's under self-help. Abby says, do I know of any hospitals in the U.S. doing it? Not directly, but I will tell you that I've had a number of patients tell me that their doctors have suggested it in their clinic. I mean, the thing about platelet-rich plasma is it's not a big medication. The risks are low because it's your own blood that they spin in a centrifuge and they isolate your plasma out of it and then use that to treat you. So, it's, you know, we're looking for more. Mary says, what about celery and carrot juice? Is it bladder friendly? It should be. I think only once in 28 years have I talked to somebody who flared from carrots. See, the thing, Mary, the thing about juices, I mean, I would suggest not juicing to start with, because juicing concentrates a lot of acid. So you think a cup of tomato juice is the juice of like 12 tomatoes. That's a lot of acid. So, and it's giving you more of that fruit than kind of your body was really designed. I mean, normally you wouldn't go eat 12 tomatoes in a given sitting. Normally you wouldn't go eat 12 carrots in a given sitting. And so the challenge with juicing is it gives you more of that fruit or vegetable than perhaps your body, it just might provoke your body in some way, especially if it's more acidic. And remember, if you are juicing and you are using a juicer, make sure you dilute it at least 2-to-1 with water. Okay, at least 2-to-1 with water. Diane says, I drank a lot of sodas after being off of them for a long time, and now out of the blue, I have back pain and pain in my pelvis. Well, honey, I mean, it's possible. It's possible that, number one, you've got some estrogen atrophy going on, depending upon your age, and now you're putting a strong acid in your bladder. Your bladder can't defend itself from that, from the acid as well, because you don't have that estrogen-driven mucus in your bladder wall. That would mean your bladder would be far more irritated, which would then trigger your muscles to get tight, which could then cause back pain. Rebecca says, I have greater than 100,000 lactobacillus in my urine. I got tested 2 days ago. I'm still waiting for a doctor to call me back and let me know if that means infection. Well, lactobacillus is, considered a normal, healthy bacteria, a beneficial bacteria. It's part of the biome. It's often found, it's just a normal resident of the genital urinary tract. There comes a point when you might have too much for one reason or another. And I'm thinking of my dearly loved friend, Diane, who we lost, unfortunately. She helped me start the IC network years and years ago. She ran our support forum. She actually had a lactobacillus-driven bladder infection. She had done massive levels of probiotics and acidophilus, way too much, and she ended up having a massive overgrowth, and they had to treat it. So it's possible. I think I've shared the story of Diane. Diane and I were opposites in so many ways. I mean, because I had all these college degrees and she hadn't gone to college. I was, doing a lot of different things. She was doing a lot of different things. I was, she worked in a diner. Oh God, I cannot begin to tell. She's with me every single day. I just love her, love her, love her. We meshed beautifully on the phone. I taught her how to code. I taught her how to do stuff online, and she reviewed books for me. And so it was just this wonderful, harmonious relationship. Unfortunately, she was murdered. She was murdered. It's heartbreaking. If you guys remember, there was a respiratory therapist in New Jersey that ended up killing a whole bunch of patients. And she was, the police say, his last victim. She was in the hospital. The one thing about Diane is that you could not tell her what to do. She had to figure it out on her own. And one thing she did is she was a massive smoker. And it's like, honey, you have to stop your smoking. But she was hiding it. She was doing it anyway. So she was having lung problems from all of her smoking. And she was in the hospital because of a lung issue. And he was assigned to her as a respiratory therapist. She was dead 5 days later. So please, fondly, when we talk about the IC Angel program, we have the IC Angel program, which we've done for well over 15 years. And that's about helping IC patients in need. That's named after her because she is our IC Angel. Rindy said she just got over COVID as well. I'm glad you're over it, hon. Diane says, what are some of the drinks I can have besides water? Chamomile herbal tea, peppermint. If you're talking cold drinks, you can have, if you can make a cold sun tea with chamomile, with cucumber, with mint. For hot teas, chamomile, peppermint. You could do a brown grain rooibos tea. You can do a herbal coffee like Dandy Blend. That's what this is, Dandy Blend. It's wonderful. No acid in it, no caffeine in it. It's about as close to coffee as you're going to get, and it will not irritate your bladder at all. And just so you know, Diane, we have a website called the IC Diet Project. So icdietproject.com. Go on over there. There's a ton of recipes. We also have a lot of drink recipes in, where is it? In this book, the IC Chef Cookbook. And so these are recipes that patients submitted over 20 years that I put together. And so some of the drink recipes in here are, oh gosh, there's a ton of hot drinks. White chocolate, vanilla bean cocoa, Karen's vanilla steamer, vanilla herbal coffee, hot butterscotch, steamed almond milk, white hot chocolate, white peppermint hot chocolate, delicious hot caramel, honey tea, hot milk with maple syrup, pumpkin pie latte, dulce de leche, pear cider, eggnog latte, chocolate coconut cream, which is carob, actually, Mexican hot carob cocoa. And then there's a whole bunch of shakes, creamy drinks and shakes, iced and sweet teas, iced coffee and coffee substitutes, fruit smoothies, herbal and veggie drinks, and alcoholic drinks. So if you're looking for recipes, the IC Chef Cookbook. This has been out now for, oh gosh, when did I do this? When did I do this? 2015, 7 years ago. And it still works today. Abby says, well, how do I feel about the next year in regard to IC research and treatment? I am really optimistic. And the reason why is because finally, in the last year or two, the research community is understanding that they can no longer do the research studies the way they used to, where they mixed all the different types of patients in one group. I mean, you can't put apples, oranges, and bananas in the same research study and expect them to respond the same way or to learn anything meaningful. And it's very clear now that Hunner's lesions as compared to estrogen atrophy, as compared to Chemo Cystitis, as compared to pelvic floor dysfunction, as compared to chronic overlapping pain conditions, very, very different, very, very different. And so now, finally, they are accepting that they can't do that anymore. So that's important because that's going to create a foundation for better studies all the way around. But the other thing that was really important that I put in this magazine, and let me just get to it real quick. New study supports IC subtypes, right? This is my editorial. So again, you guys all know that we've been using the Chris Payne's 5-point subtyping system, which I think is great. I mean, I think it's working remarkably well. But of course, there's a lot of competition, a lot of debate, a lot of doctors saying, prove it in research before you use it, et cetera, et cetera, et cetera. So Chris Payne, really kind of went out on a limb, and I grabbed onto that limb and said, these are the patient groups that I've seen in my clinic in the last 25 years. So we can start here, right? Let's debate this. Here, hold on a sec. Facebook is slow. There we go. So anyway, researchers at UCLA did their own subtyping system, and guess what? It almost virtually matched Chris Payne's. And more importantly, UCLA proved that each subtype had different therapies, that bladder therapies would not work. Uh-oh, looks like we've lost Facebook. Facebook, are you guys? Well, it went dark and it went back. All right, so I want to read this quote to you. This is from, so it's going to be a little bit academic, but it'll make sense. So this is researcher Patricia Muesigua at UCLA described the issue perfectly. They wrote, we hypothesize that the current definition of IC-BPS requiring only the perception of bladder discomfort and coexisting urinary symptoms encompasses multiple mechanistically distinct disease phenotypes. Progress in clinical care and management of IC-BPS requires refinement of our diagnostic and prognostic schema by identifying independent biologies or data that can be used to define each phenotype more objectively to correlate pathogenesis and treatment options. So in other words, what they're saying is not only do we have to understand the unique patient group, we have to understand the right therapy for each patient group. So their research, they were trying to subtype pelvic pain, and generally they had 521 women in their study. The IC bladder cohort had 145 patients in it, and in that group, they found three specific groups. Number one, bladder pain. So group one had 56 patients reported bladder pain that was aggravated as the bladder filled with urine and was relieved after emptying. So remember, we always talk about that. When is your pain the worst? Before you pee or after you're done peeing? So they define group number one is pain as your bladder filled with urine that was relieved by urination. This group had the most dietary triggers, such as acidic foods and caffeine, and they were designated the BPS group. The second group is called the NUP group, N-U-P-P. Group 2 consisted of 31 patients who had higher levels of pain in the urethra and the entrance to the vagina, and struggled with painful sex and painful urination. They had persistent pelvic pain that was unrelated to bladder filling or emptying. They believed was non-urologic pelvic pain, in other words, pain from outside of the bladder. And then the third group, group 3, which was the largest group, had the nearly identical urinary symptoms, pain levels, severity, and quality of life as the bladder pain group, but they had more symptoms related to the bowel, had frequent sensations of incomplete bladder emptying, small and urine leakage, usually without any awareness. These patients also reported more pressure, heaviness, straining to have a bowel movement. They had the most bothersome symptoms of all three groups with demonstrated pain or trigger points on pelvic examination, specifically when touching the levator muscles and the hip flexors. This group was designated the myofascial pain group. The UCLA team hypothesized that each of the three groups would respond differently to therapies, and their data supports this. The bladder pain group responded the best to bladder therapies, particularly intravesical installations and bladder analgesics. Patients in the NUP group showed low response to all bladder therapies, suggesting that their condition lay beyond the bladder. And patients with myofascial pain responded well to pelvic floor physical therapy, with 80% experiencing successful results. Now, there's no bladder therapy that's ever given an 80% success rate to the IC patient population. So this is huge. This is exactly why we're finally making progress. And, guys, the reason why I pound this away to you is because you are the educators. You got to understand that only the top tier doctors look at this research and do this. You're working with local and regional doctors. You mentioned subtypes or variants to them. They're going to go, I don't know. And I need you to bring in these articles to them. I need you to share this research with them, because we are now past the day of giving patients bladder therapies for 20 years with no success. We don't want to do that anymore. You're not responding to therapy within 6 months to a year on bladder therapies. We're going to take a step back, revisit the diagnosis, and let's make sure we know what we're treating here. And that's not from me, that's from the American Urology Association. So I'm very optimistic about the future now. I think that patients are going to find better treatments, more effective treatments. And our number one obstacle really is not the research, it's educating the doctors. I had, who was it this week? Oh, no. The woman I was telling you about who had the 4 C-sections and the other surgery, and she had the tailbone that was broken. Oh, she had terrible hip pain and leg pain and all this sort of stuff. Her urologist this week told her it was all in her head. Like, what the hell? Come on. I always say, if you ever have a doctor who says this is all in your head and you've got blood in your urine, you're going to say, sir, if this were a mental condition, why is there blood in my urine? If this is a mental condition, why do I have pain as my bladder fills with urine that is relieved by urination? If this is a mental condition, why are my muscles tight and dysfunctional? if this is a mental condition, then why does physical therapy help me? You know, I mean, that was from the 1950s. Remember, IC was first discovered in the mid 1800s. In fact, I was going to try to do that today. I just didn't have time. I wanted to go back and find that original description of IC because it's perfect for today. It's absolutely perfect for today. So they knew in the mid 1800s there were a group of patients who had bladder issues. Okay. And then in the early 1900s, when they invented the cystoscope, they were able to look at the bladder for the first time, and they saw lesions and all that sort of stuff. Then during World War II, we had our first research to show it happened to men and that it happened to children. And then in the 1950s, two arrogant pricks of doctors published a case study of a young woman who they claimed had unexpressed anger manifested in the pelvis, and they claimed that she was mentally ill. And from that point, literally through to 1990, medical schools often taught or suggested that this was a mental disease. And in fact, it was Dr. Daniel Burkhoff, who used to be our national pain expert before he passed away. He was the one who shared the story when he was in med school. He was at a class on urology. He was an internal medicine specialist. He was at an all-day seminar on bladder urological conditions. And literally at the very end of the day, the speaker is, putting all his stuff together. And he goes, oh, wait, there's one more condition I want to tell you about. These patients will drive you crazy. They're going to call you up all the time and ask for pain meds. It's called interstitial cystitis. So this was like in the late 1980s. And, he just slams IC patients, right? And then what did he say? Therapeutically, there were a couple of basic therapies, and then he said, yeah, we'll just take their bladder out. That'll shut them up. That was pretty much the attitude. And somebody, one of Dan's friends, a student in the audience, said, well, if it's a mental disease, why would removing their bladder help? At which point in time, the speaker stormed out of the room in anger. So, so understand that it wasn't until 1987, 1990 that the National Institutes of Health did an about face and said, no, this is a real condition. But we still have the legacy of many people saying this is a mental and emotional. And I was thinking of a good friend of mine who, her case is very complex. She's had pain for many, 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 many years. She was a victim of abuse. She was very badly abused when she was a child, sexually abused. And so clearly that injured her and, took a terrible toll on her body. And so she had terrible interstitial cystitis, terrible pain. And at one point in time, somebody suggested that she needed a psych hold. So they called an ambulance. They strapped her into a gurney, put her in the ambulance for 3 hours, strapped down with no restroom breaks. She's becoming more and more hysterical. The pain is that severe. She's now bawling her eyes out in the ambulance as they're driving her to the mental hospital. They get to the mental hospital, and she's begging to use the bathroom. And so they say, okay, here's the bathroom, but somebody has to watch you. And she's like, so anyway, so here she pees, however much she pees in the bathroom. They're watching her. And within a couple of hours, she was discharged with a profuse apology from the clinical coordinator at the mental hospital, who said, you do not have a mental issue. You have a very severe pelvic pain bladder issue. Abby says, are there new bladder wall treatments on the horizon? Yeah, platelet-rich plasma is one of those. But really where we're seeing the growth is going to be with the supplements. That's where we're seeing the most action right now. And so, for example, Bladder Builder is a supplement that's been out for about a year and a half, 2 years, that we're getting really, really good results with. because it has multiple methods of action. It can coat the bladder, but it can also calm nerves. It's the only supplement with PEA in it. Mary says she's diluting her juice half with water. Okay. Sorry. I mean, I always have these stories that I can share, and I don't want to. My goal here is not to share you. My goal is to show you that compared to where we were 20 years ago, we're pretty good now. But we still have a lot of work to do. That's why IC Awareness Month is so important. IC Awareness Month in September, because we all have to be ambassadors. Your job is to make it easier for the next generation. That's why I never want you to go off on your doctor and abuse your doctor and perpetuate this thing that IC patients are hard to work with. You know, you need to be professional. You need to be direct. You need to be firm, but you can't be insulting and demeaning because we have a lot to get over. Diane says, here in Georgia, they act like I'm crazy when I talk about it. Yeah. Randy says, the urologist I have is clueless and so passive to me. My urologist of 20 years who actually took time to do research and treatment retired. Yeah. Brenda says, I'm in a small town and it's hard. Yeah. Hi, Boria. If I didn't say hi already. Jean recommended hint water with no strict. I agree. Hint water is an excellent water. Excellent water. You know, it's an infused water, so you get it in lots of different flavors. I drink hint water fairly frequently. Kelly says, I had a hydrodistension this Thursday. What types of things should and shouldn't I do as my bladder recovers? My doctor really didn't give me any direction. Kelly, number one, you got to protect that tissue, hon. Your bladder's been traumatized. It's been stretched. So diet is everything. You should not be drinking any soda, nothing at all like that. I would say for at least a month, just really give that tissue an opportunity to calm down. Pay attention to any new symptoms. If you find that your symptoms get worse in the next couple of days, you want to let your doctor know, because sometimes after hydrodistension, you can have a post-op infection. Sometimes, not always, but sometimes. But I would expect that your bladder would heal very consistently now. The key question, Callie, is what did they see when they were in there? Jeannie says, I drink watermelon and berry kind water. Good. Heggy, thank you for the 500 stars. And so if you have a VA vaginal atrophy with no symptoms, should you use estrates? In my opinion, yes.
Does Hannah have an appointment on Tuesday for blood work?
No, the blood work was done. The appointment on Tuesday, it's a phone appointment with her hematologist. It's on the 8th.
Well, you know about it.
I do know about it. I made that appointment for her.
You just called.
Okay, yeah. It's a video appointment with Dr. Holmes. So, you know, should use estrates if you have no symptoms. It's all about how your skin feels and how your skin looks. If your skin is starting to show any signs of estrogen atrophy, then I would support using it, but perhaps in a very, very small amount, maybe once a week. But understand that as you get older, your skin is going to get drier and drier and drier. I mean, I've worked with some women in their 80s. Their vulvas are like dry, agonizing potato chips, and they are in agony because they never use the estrogen. And the challenge here is if you wait until the estrogen, your skin is so dry, you know, and estrogen depleted. If you wait too long, then when you start to use your estrogen, it's going to burn like hell at first because your skin is so dry it can't protect itself. And you're going to have to ride yourself the 2 weeks through that initial burning to the point where your skin is now a little bit stronger and able to tolerate it. The IC Chef Cookbook is available in our store and on Amazon. It's one of my books. Yes, you can we sell a lot on Amazon. It'd be really great though. I mean, like if you really find these meetings helpful, it would be nice if you bought it through us, because we're cheaper in the IC Network store than we are on Amazon. Everything on Amazon is like $5 or $7 more than what you can find it in the IC Network store, because that's the percentage that Amazon takes. So you're going to get a better pricing and a better deal if you just go right over to the IC Network store. ICnetwork.org is our main website, and then just click on store, and that will take you over to our store website, which is icnsales.com. Brenda said, I had one doctor tell me when I was trying to find out what was wrong with me after I had my car accident in 2003, I had to go to 4 urologists before they did a cystoscopy, and you got diagnosed in 2005. Carol says, what's my opinion of Eucora products? I don't recommend it because of the citric acid. Not at all. I think that it's going to be too damaging to those tissues. And we certainly want to stay away from anything with green tea extract, because green tea is agonizing in an IC wounded bladder. Eucora is designed for infection. It's not designed for injury. You guys, you have to remember, your bladder only knows one language: frequency, urgency, pressure, pain. So the only way that the bladder can tell you that there's a problem is by giving you all the symptoms you associate with infection: frequency, urgency, pressure, pain. So a bullet wound would feel like an infection. A stab wound would feel like an infection. Bladder cancer will feel like an infection. Everything feels like infection. But it's not infection. It's injury or trauma. The bladder can be injured like any other part of the body. And so, you kind of have to, I know in your brain you're going bladder, 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 infection, infection. But it's important that you understand that other conditions can mimic these symptoms and cause these symptoms. So Eucora is not, in my opinion, the right approach for somebody with bladder injury, with chemo cystitis, COVID cystitis, anything at all like that. Karen says, do you recommend Bladder Builder over Cysto Renew? Absolutely, I do. The reason why I do is because Bladder Builder has more methods of action. It's got the chondroitin for the bladder wall, like the Cysto Renew. It's got the quercetin as an antihistamine, like the Cysto Renew. It has beneficial probiotics for the gut, which Cysto Renew does not have. And it has palmitoethanolamide in it, which Cysto Renew does not have. What Cysto Renew does, Cysto Renew was a transitional supplement from about 10 years ago. What it did is it was the first supplement that was kind of designed to help calm nerves down, but this was before PEA. And so in addition to the bladder coating ingredients, Dr. Espinosa, who created Cysto Renew, added lemon balm. Lemon balm is not citrus lemon. It's a mint with a lemony scent that has a nerve calming effect. And Cysto Renew also has a little bit of aloe in it. So, but Bladder Builder is much more robust than Cysto Renew. But ultimately, in the end, we're all very different. We're all individual. And so what works for you would be interesting. Marcia says, what are the supplements? Bladder Builder. The top supplements for the bladder wall are going to be Bladder Builder, Bladder Rest, Cysto Protect, Cysto Renew, or Cysto Mend. Those are the 5 core supplements based on chondroitin. And it's the chondroitin that's the most important ingredient. Diane says, I was in a horrible car wreck after a guy running from the law hit me. He was going 130 miles an hour. Holy crap. And you were in a full body cast from almost everything broken, and you didn't walk for a year and a half. I think this has caused my issues in my pelvic area and that wreck. Yeah, honey. Diane, have you had a pelvic floor assessment? I'd sure love to know what's going on with your pelvic floor. I have no doubt that that was your triggering event. That's terrible, and I'm so, so sorry that that happened to you. Diane says, where do you get hint water? You can. I don't have hint water in the IC network anymore because it was really heavy and hard to ship. It was expensive. You can usually buy hint water at your local grocery store. So just go to your local grocery store. I mean, Hint has a website, hint.com, I think is the website. Let's look. No, it's not hint.com. Let's see, is it Hint Water? It's drinkhint.com. Drinkhint.com. Like a hint, they're giving you a hint to solve a clue. A hint is a clue to solve a mystery. So the flavors are watermelon, that would be fine. Pineapple, honestly, that would I mean, there's no acid in hint. So it's just the infused flavor molecule. So really any of these would probably be fine, although pineapple might be scary. The blackberry is wonderful. The cherry's wonderful. I'm a blackberry girl. I really like the blackberry. Let's see what other flavors there are. Holy wow. So they have a lot of new flavors now. Blueberry lemon, strawberry lemon, peach raspberry. Peach raspberry, that sounds really good. Peach would be fine. Mango, lemon, raspberry, strawberry, kiwi, mango fruit, honey crisp apple, blood orange, pear. And they have mixed boxes on their website. Let me just see. Hold on a sec. Zero diet sweeteners, 0 calories, 0 preservatives, vegan, gluten-free, kosher. I would love to see the back label. I do not believe that there's any citric acid in it at all. Oh, wait a second. Yeah, here it is. Made in San Francisco. Looks fine. I mean, so if you're craving your lemon, this might be what you could do. But if you're afraid of lemon, then go for it. Do the other flavors like blackberry. Yeah, it tastes great. Brenda, it tastes great. Hold on a sec. Rindy says, so it'll always be common to have microscopic blood showing up in urine specimens when you have IC, especially when you're in a flare. Yeah, pretty much. Pretty much. I mean, when your bladder wall's irritated, you know, the irritation triggers inflammation in the bladder wall, or your bladder wall's irritated, which means that something has provoked it, which means that your body, you know, your bladder lining, your urothelium is not passive skin. It communicates in a lot of different ways. And so what they've seen is that the bladder wall is able to tell the immune system when there's a problem. And so if there is an invader in the bladder wall, such as a bacteria, or even something as simple as chemotherapy, chemicals from the chemo that have entered the bladder wall, the bladder wall communicates that and says, help me, help me, help me. And so that motivates an immune response, and white blood cells are then sent to the area to kill the invader, right? But what's interesting about it is the white blood cells arrive in through the blood vessels, and they eventually end up in the capillaries of, right in the bladder lining, the little tiny microscopic blood vessels. But how does it get out into the cell? Because it's not like the bacteria is in the blood vessel. So what happens is those little capillaries open and they release the white blood cells. That also releases red blood cells. And that's why we often have microscopic blood in our urine. At least that's my understanding of it. It has to, those blood vessels, those capillaries have to open to release the white blood cells into the tissue to kill the invader. Diane says, do you do appointments where I can pay to get advice? Yeah, I do coaching every day. I did 12 calls on Friday. It's a brutal, all the way up until like 8 o'clock at night. And I did like 5 calls on Thursday. And I think out of those 17 calls, I think 3 were paid. The rest were not paid. But if my phone is on a first come, first serve basis every day. So, if you want to get ahead of if you want to get ahead of that first come, first serve line, then signing up for a coaching session is the way to do it. Because the coaching sessions always come first. And you can do that in our store. But just know that I answer the phone anyway. And if you want to spend 5 or 10 minutes talking about your symptoms, you can call, no charge. Be happy to give you a little bit of insight. Just remember, I'm not a doctor. I don't give medical advice. My job is to educate you, inform you, open a few new doors of treatment, then kick you in the butt, get you back to your doctor with a whole bunch of new questions, right? That's my job. Mindy says, I know I never had blood in my urine. I've had IC for 25 years. Okay. I've had microscopic blood in my urine every time they've tested it myself, Mindy. So the fact that you don't have blood in your urine is good. We're going to take that. That's good. And so really, again, that points me beyond your bladder to perhaps something else, right? Marcia says, can you clarify your previous mention when a body is not in alignment due to a curvature of the spine, how that can affect bladder pain? I have a curvature spine and one hip is higher on one side. I have terrible, constant pulsations beginning in the vagina and up through the abdominal area. Yeah, I can show you a picture, hon. Hold on. Let me find the picture. Okay. So this is a picture that is about a bad ankle, but it completely applies to scoliosis too. Okay. So there are a group of patients whose muscles just stay tight. No matter what you do, you're stuck with tight muscles. I mean, they can do trigger points, they can do therapy every week, but a week later, the muscle tension comes back in exactly the same spot. The trigger point comes back in exactly the same spot. And now we've got to figure out why that happens, because that's not normal. And so we have to take a step beyond muscles to bones, because what puts long-term chronic pressure on muscles but bones, especially bones that are out of alignment. And so let's look at this picture for a minute. Okay. So one of the things that Dr. Weiss was able to find in his office with patients who have long-term chronic muscle tension is that often went back to either a bad hip, a bad knee, or a bad foot, because all of these forces, especially from bad knees and bad feet, are going to be reflected directly up into the pelvis. And so this side right here is normal. So if we go down to the ankle, you're going to see that the ankle bone basically goes, this lower part of your bone, your shin bone, goes straight up, and then the femur goes slightly outwards where it connects to your hip bone right here. And so you can see that right up here, this is the normal width of the pelvic floor. Okay, of this piece of the piriformis muscle. This is what a normal muscle looks like. Now let's look at what happens here. If this person has an ankle that rolls on the inside, you can immediately see the dysfunction in the shin bone, because instead of going straight up, look, it now goes at an angle. It's going outward more. And we look at this here, we can see now that the knee is slightly out of position. And now the femur is going at a greater angle all the way up to the hip bone. And if we look at the muscle here, you can see that this muscle now is being stretched. It is wider and longer than this muscle on this side. That's one type of imbalance. So long-term chronic tension can occur from having one leg longer than the other, It can occur if you have ankles that roll in and out, if you're having trouble with your feet. It can be the result of bad knees. It can be the result of a bad hip or a bad SI joint. But now let's think about scoliosis for a moment. So scoliosis is imbalance from the torso. So in scoliosis, so a normal spine is straight up, right? But if you have scoliosis, you either have a C curve where it curves, it goes out in one direction, or you have an S curve that goes like this. So it's an S shape. So I have an S curve. And the thing about scoliosis that's also so interesting and so weird is that in that curving process, you also get rotation. You get a little bit of rotation of your vertebrae. So we're not just dealing with side to side, we're also dealing with rotational forces. And so in the end, that absolutely is going to potentially tilt one hip higher than the other hip, right? And Dr. Weiss in his book talks about mechanical injuries, wear and tear injuries. When you're young and your muscles are very pliant and your body's very responsive, your body, you might not notice it. Your body is going to be very good at compensating for these abnormal forces. And as he says in his book, we don't start seeing the long-term wear and tear injuries until your late 20s, 30s. Think about professional athletes. That's when their bodies start to give out. Because we're not, I mean, what's terrible about getting older is that we just don't heal as well and we have more wear and tear injuries. So anyway, I have in my latest magazine, we have our first article ever on scoliosis pelvic pain. And so here's a really good picture of scoliosis. Now, we don't necessarily know why it happens. There's a lot of mysteries about scoliosis. So this article, we explain what it is, what are the symptoms. For example, if you have scoliosis, you might have one hip higher or one shoulder higher than the other. If your curve is higher, you're going to have one shoulder higher than the other. My curve is lower, so my shoulders are level. You might have uneven shoulder blades, a rib hump where you have one side that sticks out more than the other. I have that. I'll show it to you. I have no shame. Let's see if you can see it. Can you see one side higher than the other? Well, it feels pretty good today. Weird. Yeah, you could see it. You could see the curve right there when I was bending over. See, look, I'm underneath on my right shoulder, my ribs are rotated just a little bit. So people with scoliosis are known for having neck tension. I certainly have neck tension. Whoops, let me fix my thing here. Hold on a sec. I tend to get spasms in my psoas muscles if I twist the wrong way. My curves are very small now. They were big when I was younger, but I lost a lot of weight. I think the reason why my scoliosis happened is in my family, I'm telling you, watermelons. The women in my family generally have huge bosoms. My poor grandmother, I don't know how she did it. She had 2 giant watermelons hanging off of her chest. So I was like a 38D in 7th grade when this all happened. So I had a big growth spurt. I had a 6-inch growth spurt one year, and then I had like a 4-inch growth spurt the next year. And my curve happened during that second growth spurt. And I just think I was too top heavy, and I don't think my spine could support it. Plus, I was not very strong. I was not an athletic kid. I was kind of a chubby kid who watched TV. And that was when I stopped watching TV and got fit. I could tell even as a kid that carrying extra weight was not good. And so I got involved and started playing tennis two-handed to try to straighten my spine. And guess what? It worked. And my spine improved by 50%. So anyway, yes, scoliosis is definitely an issue for some people. John says, which of the 5 would you recommend starting with first? Bladder builder, it would be my first choice, but only if you're not sensitive. If you can take a probiotic and you don't flare from a probiotic, I would say bladder builder. But it's a pretty rigorous, aggressive formula. If you're somebody like me who you are more sensitive, I would start with bladder rest. The water is hint water, Rindy, hint. Judy says, how does Sjogren's relate to IC? I was just diagnosed with this. So there has been kind of misinformation that has gone through the IC community. A lot of people are they make statements that everybody's the same. And so there are some people who say IC is an autoimmune disorder. That is absolutely not true. IC does not meet all the criteria to be an autoimmune disorder. That's why we have all these subtypes now, because chemo cystitis is not autoimmune, pelvic injury is not autoimmune. However, there certainly is a small population of patients who do have autoimmune conditions. Sjogren's syndrome, Zika, lupus, rheumatoid arthritis, and we were just talking about this at the International IC meeting in December, because I presented them Dr. Payne's subtypes, and Jane, who runs the International Pelvic Painful Bladder Foundation, she goes, where's the autoimmune subtype? And it's just not, it needs to be in there. I don't think we really know how to categorize it yet. Hold on a sec. So the last 2 academic guides that were published was this book. These books are like $120. Okay, these are academic textbooks for doctors. So this is bladder pain syndrome, and then this one is urologic and gynecological chronic pelvic pain. So hold on a sec. Let's just So there's no section on that in this one. And here, hold on. Let me see what they say about. Okay, hold on, page 17. Hold on. Okay. So speculations on possible autoimmune etiology of IC led to an investigation among patients with Sjogren's syndrome in Finland. All women aged 18 to 71 in the Finnish Sjogren's syndrome patient organization, which is 1,200, filled out an IC questionnaire. The response rate was 81.5% of the Sjogren's patients. Subjects with high symptom and problem scores without urinary infection or pregnancy were regarded. Okay. According to these criteria, 5% of Sjogren's syndrome patients fulfilled the criteria for IC. Okay, that doesn't really help us. Hold on. You know what, man? You just triggered something for me. Hold on. Hold your horse. Hold our horses for a moment. Wait. I don't think Jane watches these. Hold on. Just give me a second here. I just want to email her. Hold on. Hi, Jane. I'm doing a live meeting right now. And someone, let's see, one of our members was asking about the connection of IC with Sjogren's syndrome. And it, made me wonder if there is a published treatment protocol for autoimmune driven IC symptoms. Has ESSEC or anyone else that you know pursued this further? I don't know why. All right. I will get back to you. Okay. Sometimes you like have those moments where you go, why haven't I asked this question before? There's just so much. All right. Boria says, I have a bad hip and knee. I had replacements done on hip and knee, and you still have back problems. Yeah. Randy says, do you think IC is a direct correlation to vaginal atrophy? Absolutely. It's called the genitourinary syndrome of menopause, also known as GSM. It is a slam dunk correlation. IC subtype 2 bladder wall driven estrogen atrophy. We talk about it every single week, hon. I have a video on our website called the Estrogen Chat. So, and it's, I think one of the things that just stuns me are the number of patients who the doctors see the estrogen atrophy, but they don't explain why that affects your bladder. And here's the deal. Think about your bladder for a moment. It's the only organ in the human body designed to hold toxic waste, right? Because urine is body waste. Urine contains ammonia and urea and all sorts of issues. And so how does a bladder protect itself from all that? How can the bladder hold ammonia for hours at a time? I mean, it's really an evolutionary miracle in a way. And the answer is that your bladder is like your mouth. It's a hollow organ covered with a really thick coating of mucus. And the purpose of that mucus is to act as a barrier. So your bladder's wet on the inside. It's like your vulva and your vagina. It's wet. So unfortunately, that nice, thick, mighty mucus is estrogen dependent. So when you're young and you have lots of estrogen, you have lots of mucus and you can get away with stuff. When you're older, you have much less estrogen, much less mucus. Thus, your bladder's ability to defend itself is now compromised. It's dry. That's not a disease process. That's just estrogen atrophy. They changed the name from estrogen atrophy to the genitourinary syndrome of menopause. And so the fact that you're dealing with this and now you've been prescribed Premarin, so just know the Premarin is well known to be irritating. It has alcohol in it and other preservatives. So most of us cannot and do not use Premarin. We do better with a preservative-free estrogen cream or estradiol cream. So you're not alone in having burning with Premarin. A lot of women report burning with Premarin. We never suggest that. Instead, ask your doctor for a compounded preservative-free estrogen cream. I get mine from the Women's International Pharmacy. Well, you have thyroid issues and fibro. So do I. I have a hypothyroid. I don't have fibro. Praise God, hallelujah. You get tired of your IC being the result of elevated blood levels. Well, again, there are things we know and things we don't know. Mary says, estrogen's not helping my bladder, so I don't get it. How long does it help for the E string to work? Well, remember, guys, that the urethra is often what we call the canary in the coal mine. It's the first part of the urinary tract to start screaming from estrogen atrophy. And so the challenge with E-string and the challenge with Vagifem, which is a tablet you insert, is that you can't put estrogen where you might need it the most, which is at the urethra. And so that's why using a cream, a compounded cream, is a little bit more effective for directing it where you need it to be. It's not an immediate bladder therapy. You just have to understand that dry skin hurts. Dry mouth hurts, dry bladder hurts, dry urethra hurts, etc. And so estrogen is about improving your skin quality, right? It's just about improving your skin quality. Sue says, if I start with bladder rest, should I use Peora, Poly 500? If you have pain, yeah, why not? I mean, that's what the research showed, that it was very good at reducing pain. Judy says, I just started Bladder Builder. I've not opened it yet, but I do have a very sensitive stomach. Can I return this and get something else? Sure, you certainly can. Judy, if you flare when you eat yogurt or take a probiotic, absolutely return it. Because you want to swap that out for bladder rest. So just make sure you return it in an envelope with tracking so that we can track it and see where it is, because it's amazing how many things get lost in the mail these days. I had an order for Australia that sat in the San Francisco mail center for 6 weeks, and the customer was going, where is it? Where is it? Finally made it onto a plane 2 days ago. But the other thing is, you could always just try one capsule and take it with food and see how you do. You might be one of those people like me where I could never take more of one of any of the chondroitin-based supplements. If one a day worked for me, 2 a day started giving me loose bowel, and 3 a day was impossible. And so when I was taking these supplements, I did 1 a day. Now because I know my bladder's in good shape, I don't take a chondroitin-based supplement. I just take Peora to calm my nerves down. Brenda says, I've heard some people say that IC is autoimmune. The answer is no, it's not autoimmune for everybody. I just went through this, but there's a small population of patients where it might be autoimmune driven. For those patients who have who have lupus, Sjogren's syndrome, rheumatoid arthritis, etc. Sue says, do you know if women with a hormone positive breast cancer can use products like E-string? Topical estrogen is considered remarkably safe, but that's in the cream form rather than the E-string. The E-string is delivering estrogen directly through your skin in higher quantity. So you can Google it. There have been multiple studies which have found that estrogen cream stays in the skin and does not pose a greater risk to previous gynecological cancer patients. I would think that the cream would be less risky than the E-string, because the cream is often used externally, whereas the E-string is up into that tissue. I was at a conference sometime in the last year where this question came up, and a doctor said, if you're worried, use it externally rather than internally. But you got to do the research. Google topical estrogen safety. Carol says, can you repeat what we should ask our doctor instead of Premarin? Ask for a compounded, preservative-free estrogen cream. and it's called the genitourinary syndrome of menopause. Ginny says, are any supplements available in Canada? Not really. We send them there. You have to buy them from the US, or if you happen to be close to the border between Canada and the US, a lot of Canadians have US post boxes, and we ship to their post office boxes. So you don't have to pay customs. Or if you have somebody in the US that's a relative that we can ship to, then they can ship it to you. That's one way of reducing your customs charges. Arlene says, I thought subtype 1 destruction of the bladder wall by the body was autoimmune. I see subtype 1 Hunner's lesions. Well, Arlene, we might have said that a couple of years ago, but now we have a case of somebody with Hunner's lesions who also had that severe bladder prolapse. Oh, by the way, that patient I was telling you about, she also had what we call posterior fornix syndrome. And so this is a patient with severe Hunner's lesions, big bleeding wounds on her bladder, and a severe prolapse. And so they surgically went in to repair the prolapse because she couldn't pee correctly. And when they got in, they made a remarkable discovery. Her uterus was swinging on a tendon. So normally your uterus is anchored. Your uterus and your vagina are anchored on both sides, so it doesn't move. She lost one. One of them was broken. And so her uterus was doing this, right? And so the patient I was working with, the one who the doctor said, it's all in your head, the back of her uterus was facing front and the front of her uterus was facing backwards. So she also was a case of somebody with what we call posterior fornix syndrome. So what was amazing about this case study is that when they repaired the prolapse and they repaired this, her Hunner's lesions disappeared completely. She's a complete cure. And so the question is why? It's called a torsion industry or strangulation. That when something is twisting like this, think about the blood vessel. So here's your uterus. So imagine you have a blood vessel that comes here and provides blood for this part of the uterus. Well, if you're swinging, that blood vessel is twisting. And as that blood vessel twists, it reduces blood flow. So anyway, and in addition to twisting and interfering with blood supply, we're also twisting and interfering with nerves. And it's the thought of neuroinflammation, nerve inflammation, that has really been one of the dominant theories underlying the development of Hunner's lesions, along with viral infections. So Arlene, the other thing too now is we've got research not only from Europe, but from the United States, which has found that some patients with Hunner's lesions have a viral infection in their bladder. So that also is not autoimmune. Now, COVID cystitis, that's another story. Because COVID, I was reading a devastating paper about long haul COVID a couple of days ago. COVID cystitis does trigger the immune system, and it does cause immune dysfunction, and it does cause a cytokine storm. So some patients with COVID cystitis have the cytokine storm. Other patients with COVID cystitis might have a nerve injury. Still others, though, might actually have active viral infection in their bladder wall. So it's not simple. It's very, very complex here. Randy says, thank you, you've been more informative. That's what I try to be, hun. But, I'm not perfect. I might get things wrong, too. That's why I try to pull out these books and give you references and resources. Randy said, when I told my doctor the Premarin was irritating me, estradiol was the next option. That's correct. Does that include preservatives as well? You will need a prescription for the compounded estradiol. Yes, you will need the prescription, and you can ask the compounding pharmacy to make it preservative free. Just understand, Rindy, that if you're super, super dry down there, let's just say because I can't tell how old you are, hun. So let's just say you're 70. Hey, I'm 61, so there you go. You know, at the age of 70, you're well a decade into estrogen atrophy, and that skin will be very, very, very dry. Or if you've been had a hysterectomy or you've been on Lupron and you're in chemical menopause, the longer you've been dry, the much more sensitive your skin is. And so anytime you use any chemical down there, it's going to burn. So even compounded estrogen could potentially burn at first. Okay, you're 39. Sorry, honey. We're always guessing. Your little picture here is like the size of a pea, so I can't really see your face well. Sorry about that. So, but if you've been in chemical menopause or surgical menopause because of a hysterectomy, let's say you had a hysterectomy 10 years ago, you're going to be pretty damn well dry. And so just be prepared for the fact that sometimes there's an adjustment period of about a week or two where you start using your estrogen cream and it might feel hot. It's not burning you. That's just a direct reflection of the quality and health of your skin. Just means your skin is very dry. But every time you use the estrogen, your skin immediately absorbs it and starts to produce more mucus. So that heat slowly but steadily goes away. It took about 10 days for that heat to go. When I first started using my topical estrogen at the age of 51 or 52, I had burning for about a half an hour. Maybe 3 or 4 applications later, it was like a warm puff of air. It was like a poof, a little puff. And a second, 1, 2, 3 seconds later, the heat was gone. So just know that your skin immediately uses that estrogen. The other thing about Premarin is it's very expensive. Premarin can cost $220 for a 3-month supply, where compounded estrogen might be $50. So from a cost standpoint alone, if anybody gives you grief for not wanting to do Premarin, it's just like, I can't afford it. Easy peasy. But Premarin is notorious for causing more extraneous burning. Rindy says, hi, Bonnie, by the way. Nice to see you, hon. Rindy says, I honestly don't know what caused this. Well, again, we have our subtypes. We've got Hunner's lesions, bladder wall-driven, pelvic floor-driven, pudendal neuralgia, and central sensitization. So a good place to start would be over on our website and read the section on subtypes. Because it could be something as simple as you falling on your tailbone, or it could be related to estrogen atrophy, or it could be related to a chemo cystitis, chemical injury to your bladder, or it could be related to, other things, Tarlov cysts, fibroid tumors pushing on your bladder, endometriosis, pelvic congestion syndrome, having a bad foot, a bad knee. I mean, there are multiple, you are an anatomical mystery to be solved. That's why when you go see doctors, I always say, don't walk in and say you've got IC. It's a mistake. You have to walk in prepared to discuss your symptoms and then ask the doctor, can you help me understand why I'm having this symptom? So if you have pain, again, this patient I was working with, I think I talked with her for about 2 hours. She said, and again, trying to get information out of you guys is hard. It was difficult. I had to ask you a lot of questions to try to understand what was going on. I said, where's your pain? She goes, on the left side. And I go, that's not your bladder. She's like, it's not? No, your bladder is centered immediately above your pubic bone. If you have pain to the left or to the right of center, that's not your bladder. That's probably something related to your pelvic floor or potentially something else. Mary says, problem is burning causes me a bad bladder flare-up. It can. That's why something like Peora, which can calm nerves down, might be really, really interesting to try. All right, guys. Well, listen, it's 3:00 and I have something else that I really need to do today. So we've been doing this for about 2 hours. So I think it's time. I think I need to go ahead and stop doing this and move on to my other thing. So I'm going to wish you all well. And I hope that you have a wonderful rest of the weekend, a wonderful Sunday night. Here's your homework. For 15 minutes a day, I need you to do something to give you some comfort. Go sit out in the side in the sun, or go walk through, take a walk through a park, go to church if you like to go to church, whatever will give you a little bit of comfort. For 15 minutes a day, I need you to do something for your bladder, your pelvic floor. That means, yes, you get down on your back on your living room floor and do the exercises they told you to do here. For 15 minutes a day, I need you to do something to work on your knowledge, right? Because listen, you can't assume that Facebook or me is going to be the entirety of your IC knowledge. And we have wonderful books. One of the best books you can get right now is this book, IC 101. This is we just released this book last fall. Took us 2 years to do, and it's the first book to talk about subtypes and to talk about all these variants. And we will be updating it. I will be updating it probably this summer. We'll see. And then last but not least, I need you to laugh because when you're laughing, your brain does not intensify pain. The challenge is when you're in pain, you get anxious, and anxiety intensifies pain because your brain goes into fight or flight and thinks your life is at stake. But if you're laughing, your brain goes, well, your life must not be at stake. It will not intensify that pain. It will calm things down. And so you have my permission to be on TikTok or YouTube or watch funny movies, every single day. It's very important that we bring laughter back into our lives. Very, very important. So, all right, my friends, I will see you later. If you like what we do, please come on over to the IC Network and think about becoming a member so you can get our magazine, the IC Optimist, and a lot of other things. Also, if you're a $100 member, you automatically get the IC Chef Cookbook. So anyway, all right, I will see you guys later. Have a good one. Okay, goodbye, Facebook. All right, YouTube. See you guys later, hon. Have a good one.